हेलो।
Yes.
जी सर, स्टार्ट कर सकते हैं हम।
Yeah, we'll just wait for 1 minute and then we'll start.
Okay.
Good evening, sir.
Good evening, Peeyush. Good evening.
Good evening, sir.
Good evening, Dr. Naganath. Good evening. So it's 7. I think we can start.
Good evening.
Good evening, everyone, and
Thank you,
good day
sir.
to others who have joined from other time zones. Today is the 10th masterclass. Masterclass is the monthly online academic activity of the Jaipur Surgical Tutorial, which is again an online education portal that we started when I moved from Lucknow to Jaipur. And this is being managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery and liver transplant with me at the Mahatma Gandhi Medical College and Hospital in Jaipur. This program has been running for last 3 years. In between, I'll keep projecting information about the Jaipur surgical tutorial. We conduct a class every Saturday, 9 to 10 a.m. India time. In addition, recently, a few months ago, on the request of colleagues from Africa, we started a Friday afternoon activity, Jaipur Surgical School, where we hold a class 3 to 4 p.m. India time, and that has been managed by Dr. Peeyush Varshney, who's my colleague at AIIMS Jodhpur. And master classes are actually single theme sessions which we hold on last Thursday and Friday of every month, 7 to 9 p.m. And as I said, this is the 10th master class. We covered living donor liver transplant, safe coli, acute pancreatitis, chronic pancreatitis, intensive care, and various other topics. And the technical support for all these online sessions is provided by the team of Dr. Avinash Tank, my former fellow from SGPGI, who's currently at Ahmedabad. And they have uploaded all the previous sessions videos on the YouTube channel of Gastro University. So all students are welcome to watch these videos on that channel. In between the sessions, I'll keep projecting information about the new participants, new students who would like to join these sessions. And it is very heartening that although the live attendance at some of these sessions is not very high, but as we have been seeing that in the following days and weeks, the views of all the uploaded videos are in very encouraging numbers. So the efforts put in by all the faculty, both the moderators and speakers, I think are being utilized by students as well as practicing surgeons, the purpose for which these sessions were started. So with that brief introduction about our online educational activity, I would like to introduce the moderators for today. Dr. V. Sitaram is one of the senior most HPB surgeons of the country. He had a long stint at the Christian Medical College in Vellore, and he's now retired, but still actively involved in academics. And I'm very grateful to him that he accepted my request to join our sessions on a regular basis as much as he can. And we look forward to his participation and contribution. And along with him, Dr. Avinash Supe, who was formerly the chief of GI surgery at KEM Hospital and is currently at the Zen Hospital. Again, a great educator of the country. So today's session will be moderated by Dr. Sitaram and Dr. Supe. There's a slight change in the sequence. Dr. Vishal Gupta is still busy in the hospital, so he's requested for the last slot. So Peeyush will shift to the 7:30 slot. So with that, I hand over to Dr. Sitaram and Dr. Supe to please conduct the proceedings.
So, sir, what is the pattern? First, somebody will present and then we have a discussion. What is the kind of pattern?
Yeah, I think if you any one of you want to make some introductory kind of remarks about the theme and general remarks, and then each presenter will have 15 minutes. You have 5 minutes for the moderators, and 10 minutes will be the question answer session. Questions will come on the chat, which Himanshi will send to me, and then I'll read them out. Yes, please.
Sitaram, you want to start first?
No, I think you go ahead.
Sure. Thank you, Dr. Kapoor. I think everybody in his lifetime as a surgeon always undergoes anastomotic leak. I think if you're not got anastomotic leak, that means you've not done enough amount of anastomosis. That's I would say. So I think this is a very important topic, and I really appreciate Dr. Kapoor's efforts of really spreading this. And I would request the first person to really start his presentation. And I'm sure I request everyone who has any questions can send them to Dr. Kapoor, and then we will definitely solve all these kind of questions.
We'll introduce the first speaker. First speaker is Dr. Anshuman Pandey. He again is my former fellow from SGPGI, and now he is the chief of surgical gastroenterology at the RML Institute of Medical Sciences in Lucknow, another tertiary care level institution founded by the government of UP. And Anshuman is going to talk to us about the techniques of anastomosis. Anshuman, please share your screen.
Okay. Good evening, everyone. So, is my screen visible, first of all?
Not yet, actually. Can somebody help from the technical team?
First, you open your presentation on your screen, and then click the green button at the bottom.
But I did that.
Share screen. Yes. Yeah, there is some
Here
problem
we
with
can
Zoom.
see you. We can't see your screen.
Yeah, last time also we had some technical issues. There is some problem with the Zoom software. It's not you. Once you share the screen, it's not working.
Is it coming, sir, or not?
No, not
Okay.
I think stop sharing and then share again.
Reshare again, actually.
Yes.
Actually, you close your presentation, open it again, and then you start again. Maybe it works sometimes.
Yes. Himanshi, we need to look into this. Last time also ये problem हुई थी कुछ speakers को. Is it a problem with Zoom or is it हमारी कुछ problem है?
शायद सर जूम में तो नहीं है, योर सिस्टम में होगा.
Just give me a minute, sir. I'll do that.
Yes. Take your time.
So I'll rejoin the meeting, I think.
I think log out and rejoin. Sometimes that works. In the meantime, Dr. Sitaram or Dr. Supe, if you want to make some general kind of remarks.
Sure.
While Anshuman is coming in.
I always feel that anastomotic leak, different organs have different kind of and the risk which is always involved. And there are, I'm sure, many elements of anastomotic leak. It's not only your technique, but how you really select a patient, what is the disease pathology, what are the way you really use your instruments and your sutures, and overall post-operative management really has a lot of involvement into anastomotic leak. So anastomotic leak should not be really said it's only technical fault. No, it's not a surgeon's fault alone. It has many factors. So I think one should understand this. So if you understand that, especially your surgical decisions of where to do anastomosis and the vascularity of that anastomosis, if you understand that, I think that many times is the reason for getting anastomotic leak. So I think when we understand this topic from beginning, from anatomy to almost the way we diagnose, what are the early features of diagnosis, I think we must really understand that there are some factors which are under control of surgeon and some are not under control of surgeon, directly or the technique. If you understand this,
Dr. Anshuman is still not the co-host. Please make him a co-host.
Yes, sir.
Anshuman, are you with us? Yes, good.
Yes, now we can see. Now we can see. Good. Please start.
Anshuman, your hospital looks lovely.
Yeah, it's a relatively new. It was created much after SGPGI was created. Anshuman, are you there? We can't hear you. We can see your screen. Is he there? Anshuman, unmute करो अपना. Anshuman, you are muted.
Anshuman, we are not able to hear you.
I'll call him. तुम्हारा स्क्रीन दिख रहा है बट वी कांट हियर यू. तुम्हारा म्यूटेड है माइक. ऑन करो उसको. अनम्यूट करो. Sure. Himanshi, can you click on that ask to unmute, because Dr. Anshuman says that he can't unmute himself. हाँ, एक बार फिर से करो. I think there is some problem.
Is he joined as a fellow or he joined as a faculty? Maybe the students don't have right to unmute.
नहीं, actually students को तो they are watching on the YouTube.
Okay.
So this link is only for faculty. He is co-host, but he's saying he's trying to unmute himself, but he's not able to do it. So maybe he'll.
Yes. हो गया, sir.
Okay, finally, I think, but the video is not showing. I'll go back again.
नहीं, but अभी तुम्हारी आवाज आ रही है. ठीक है.
Sir.
हाँ, start from the first slide.
Let me see whether is it being shown, sir?
Yes. Introduction.
Okay.
We can see the introduction. Yes.
Okay, finally, maybe I'll show myself also later because something is wrong. So good evening, everyone. So it's a very interesting topic. Why? Because it's a very basic one. And as my moderator has said, that everybody who hasn't got a leak hasn't been performing surgery. So it's a Greek word, and it shows that anything without a stoma or a mouth would be termed as anastomosis. So it's a very simple thing that a key to a successful anastomosis is an accurate union of two viable bowel ends, and of course, without any tension. So most important factors which would be important in creation of bowel anastomosis would be a meticulous technique, a proper blood supply, and it should be tension-free. Now, this technique depends upon the site of anastomosis, the caliber of the bowel being anastomosed, the underlying disease processes, contamination prior to your surgery, that is an emergency setting or an elective setting, or perforation, any kind of vascular compromise, trauma, and associated bowel edema. The available expertise, time, and of course, the equipment and the things which are available at that point in time whereby a person is performing the anastomosis. So one important factor to perform a particular anastomosis remains, however, the experience of a surgeon, which is of paramount importance. The intestine tissue or intestinal tissue should be opposed with the serosa to serosa component, and the mucosa should not be pouting out, or it should not be visible from outside, as it should be inverted rather inside. The familiarity with the tissue, that is normal, abnormal, ability to predict how it will interact with the anastomotic technique allows the surgeon to select the technique, and with optimal tissue compression. Any kind of overcompression would lead to ischemia, necrosis, fistulation, or undercompression may lead to bowel not being anastomosed properly and giving rise to leak. An important aspect is the anastomotic size. What should be the anastomotic size? It should be adequate enough to and patent enough to admit regular flow of enteric contents. And it should be without generating any sufficient wall pressure to cause the disruption of the continuity of the bowel. Any kind of back pressure due to obstruction may lead to problems later. So it should be tension-free, both in terms of the anastomosis and also egress and ingress. The anastomotic aperture side should be at least matching the cross-sectional area of the surrounding intestine. So it's important that not only the stoma size, especially in a side-to-side anastomosis, the aperture of the bowel, that is the lumen whereby the egress is taking place or the ingress is taking place, should also have an adequate size. It should not be obstructing at that point in time. In stapled anastomosis, which is now a big thing, especially in robotic and laparoscopic surgery, the limiting factor on flow rate across the anastomosis is not typically the anastomotic diameter itself, it is the surrounding anastomotic aperture size. The cross-sectional area or the cross-sectional diameter is the important fact, because we may actually have a very big anastomotic size, but the egress is small. Tension-free anastomosis, that is, the anastomotic end should overlap without having excess tension or undue pulling. The methods for achieving tension-free anastomosis, maybe we can take an example of ileal pouch anal anastomosis, is taking or rather mobilizing the root of the mesentery. The mesenteric scoring, like a transverse cut, that is a pie crust fashion cut, whereby you may increase the mesenteric dimensions and reach the bowel to deep into the pelvis. And sometimes a ligate, a vascular pedicle, that is ileocolic pedicle in this case, whereby you can reach the bowel to a certain extent. So all these maneuvers are done predominantly to have a tension-free anastomosis. If it is tensed, it may give rise to problems and leak. There are multiple procedures or maneuvers which have been described, and all these procedures are prescribed for specific surgeries, like one of them is Vellore, and this is what it looks like. One of the most important thing would be the adequate perfusion, which leads to proper healing of the tissue, and it actually is the key to prevent any kind of anastomotic leak. So on table, one may assess adequate perfusion by the color of the bowel, which was described very well by Kollega. It should be ideally pink and healthy, and sometimes, if you just press upon it, it actually blanches and comes back to its normal self. Observing the pulsatile flow at the cut section, once you cut with the scissors or sometimes even with the cautery, it may have proper blood supply, which was described by Norman and Louise. Sometimes you may even go to the mesentery and see whether it is pulsatile, whether there's adequate blood flow or not. So all these things actually decide that whether the transaction line is having an adequate blood supply. Sometimes nowadays we have got more reliable and objective methods of assessment. It may be a handheld Doppler or a digital Doppler ultrasound, or even a bigger Doppler ultrasound, a spectroscopy, a light spectroscopy, fluorescent techniques which utilize the fluorescence perfusion angiography, and laser spectral contrast imaging, which may be dye-free. So this is how it looks like. It may be done laparoscopically also, even in open techniques. The fluorescence perfusion, we may actually see whether what is the transaction line. It is very beautifully depicted over here with maybe infrared or even ultraviolet rays. The laser spectral contrast imaging, here we can see that the laser is being depicted in the small bowel, and the terminal part of the bowel, which is actually looking normal in the right-hand side of the picture on my screen, it does not have a proper blood supply. So it may be a potential area to leak if we anastomosis in this area. The other factors which are affecting anastomotic leak are not necessarily related to the technique itself. It may be because of the patient conditions also, the emergency settings. The positive factors are accurate seromuscular apposition, no distal obstruction, and of course, not giving rise to any kind of mesenteric window, closing all the mesenteric window so that an adequate blood supply and there's no tension of the bowel movement later, whereby the bowel may migrate to an area which may lead to any kind of vascular compromise. The negative factors may be a significant amount of fecal contamination, a hematoma formation, which is done at the time of surgery. You may have a large hematoma, and sometimes you may actually have to wait and see whether you need to re-resect once a hematoma is large enough, which may actually jeopardize your anastomosis. The patient factors are important. A proper patient with a young, good nutritional status, hemodynamic stability is there, the healthy bowel ends are there, the good vascular supply, a non-smoker patient. So all these things would be the positive factors. Any patient who is immunocompromised on high dose of steroids, an elderly male or female, anemia is an important factor. Sometimes underlying medical conditions like diabetes, which is uncontrolled uremia, may give rise to your bowel leaking. Antecedent history of continuous smoking, alcohol abuse. Nowadays, although this is mentioned there, but preoperative radiotherapy, but nowadays we operate in neoadjuvant setting also. So it may be questionable, but still newer techniques of radiotherapy whereby they deliver concentrated radiation at the area may actually be better rather than giving a general radiotherapy. And one of the factors may be male sex in colorectal anastomosis, may be due to anatomy, may be due to vascular supply. So this is the basic phase of healing, whereby within hours we have inflammation, whereby the platelets, keratinocytes, cytokines come. In days they have proliferation, whereby the pro-inflammatory macrophages and neutrophils come. And then subsequently the remodeling part, whereby the collagen fibers form. And this usually happens in weeks. So one initial part of the time, you have to give proper, decent anastomosis to the patient so that the remodeling occurs properly. So anastomosis can be described as sutured anastomosis or stapled anastomosis. It may be simply interrupted or continuous with a single layer sutured anastomosis or a double layer sutured anastomosis, an end-to-end anastomosis, side-to-side anastomosis. End-to-side anastomosis means the proximal and the distal end relationship in terms of end-to-end, the side-to-side and end-to-side. It may be extramucosal, that is onto the serosa, or full thickness sutures. So all these things are basic things. You may have variations of it, but these are the types of sutured anastomosis. The stapled anastomosis, again, it may be side to side or end to side, and they are dependent on various stapling devices. Nowadays, it is nearly universal to have a 3-row staple, which is known as tri-staple technology, which is used in our scenario, which we'll discuss. So sutured anastomosis, technically it is two ends using sutures and needles. Healing of anastomosis and recovery from the surgical damage is both impacted by the suture material and the structure. So an ideal suture, maybe people say that an ideal suture is not made as yet, but still it should cause minimal inflammation and minimal tissue reaction and provide adequate or maximum strength during the lag phase of wound healing. Once the wound is healed, then the collagen is formed, properly remodeling is done, then the suture may actually be absorbed. So popular choices, polygalactin, that is Vicryl, polydioxazone, that is PDS, and silk. Apart from that, there are various other sutures which are usually used. So synthetic absorbable monofilament suture materials are usually preferred. They are absorbed primarily by hydrolysis, hence they have a predictable outcome. Monofilament sutures are usually less traumatic as compared to the braided ones, but sometimes they have more memory that is difficult to handle, especially in laparoscopic scenario. But still, monofilament sutures are preferred. Nowadays, we have braided sutures also, but again, that is a separate scenario. Monofilament sutures are usually preferred. Small suture material 30 would are less likely rather to trigger inflammation. So 30 suture with an adequate size is a good enough scenario, and most of the centers they use 30 sutures. Just a word about the types of sutures. We know about the Lambert sutures. There may be multiple variations of it, but still it holds the test of time. That outer layer of two-layered bowel anastomosis, 3 to 4 millimeter lateral to the incision. They are usually only seromuscular, and they may be interrupted or continuous in manner, and they repair the seromuscular tears too. Another form of suture is the Halsted or the horizontal mattress. Now, this is an important suture. Why? Because some people use it in the anterior component of the invagination technique of the pancreatico-jejunostomy also. It distributes tension in a plane perpendicular to that of a Lambert suture, and it is usually horizontal mattress. We'll just show you the picture. The apposition of tissues has less crushing effect. They are more opposed rather than crushed together. And it is useful predominantly in damaged, inflamed, or soft tissue, which is handled with care. Another component is Zerny's Lambert suture, that is double layered. Some people consider it as a gold standard for bowel anastomosis. The inner full thickness, continuous absorbable sutures, and outer layer of interrupted, often permanent seromuscular or Lambert sutures. So this is the most commonly done scenario, whereby the inner sutures are absorbable sutures, and they may be continuous or interrupted depending on the preference. But usually interrupted is preferred in terms of this thing, because the continuous sutures may actually compromise on the luminal vascular supply. Another suture is Gamby suture, which was essentially used in pyloroplasty, which is an interrupted single layer suture, and it inverts mucosa, creates full thickness inverting suture line, and used typically absorbable sutures are used. Another form of suture is cornel suture. They are full thickness, usually continuous. The mucosa is inverted into the lumen of the bowel anastomosis, that is the knot inside the lumen, and absorbable sutures are generally used in this scenario also. Cushing suture, same as cornel, except the suture does not enter the lumen, but it rather exits through the submucosa rather than the luminal knot. So these are a few pictorial things: interrupted Lambert, continuous Lambert, Cushing's. One of the sutures is a purse string, cornel suture, and on the right-hand side extreme is the Halsted suture, used in difficult tissue scenario whereby the sutures are not holding very well. So single or double layer anastomosis, of course, everybody does it with their own experience. Neither technique is inferior in terms of preventing any kind of scenario post-operatively. But single layer anastomosis is simpler, less expensive, as they say, quicker to perform. Reductions in ischemia, that is the most important thing, tissue necrosis, and narrowing of the lumen. So anastomosis and trauma, especially, gravitates towards double layer anastomosis, because sometimes the inner layer only or a single layer anastomosis may create problems. Interrupted versus continuous sutures. Continuous sutures are usually watertight. They improved hemostasis is there, but sometimes integrity is only on one stitch. Subsequently, they may lead to ischemia and hence any kind of bowel dehiscence. So studies, they show, the references are there, that continuous anastomosis can be performed safely and quickly. And although there's no significant difference between continuous and interrupted suture patterns, but usually teaching says that in a difficult scenario, we should use interrupted sutures because any kind of a purse stringing effect or any kind of difficult scenario in terms of ischemia should not be compromising the bowel at that point in time because that is already compromised. A word about inverting and everting. Nowadays, it is confirmed that everting sutures are usually not indicated and inversion techniques are better because the mucosas are buried inside and it gives rise to superior bursting pressure, more prompt bowel architecture. Therefore, the inversion techniques are better. Here are a few pictures whereby we see that although it is a bit of zoomed out picture, but still we can see that a side-to-side anastomosis is being done in typically 4 layers, the inner 2 and outer 2. The inner layer is absorbable, which is vicral, and outer layer is silken. Again, a sutured end-to-side colocolic anastomosis. The end and the side here, again, a single layer suture is done with a silk suture. A word about stapled anastomosis. Nowadays, a lot of stapled anastomosis is being done. The surgical principle remains the same. They ensure viability and reasonable condition of the tissues to be manipulated. To exclude a distal obstruction is must. Carefully evaluate the areas that have experienced radiation, peritonitis, local changes, and avoid tension on the staple lines, as was the case in terms of suture 2. We have to have precise dissecting of the tissues and which are basically incorporated inside the anastomosis. So the most important thing is adequate compression to cause hemostasis and prevent leakage. Most of these stapled anastomosis are done laparoscopically or robotically. So you have a loss of tactile sensation, but there has to be an adequate hemostasis and compression, thereby leading to an adequate anastomosis. We have to ensure that the staple is properly loaded and configured in proper orientation. The safety mechanisms are usually done left at the last moment, that is once the compression is complete and we are ready to deploy the stapling or staple line. Usually, a bit of time has to be given so that the bowel edema and compression moves away from the staple line and there is an adequate anastomosis. If the bowel is very edematous, sometimes you may actually tear the bowel and it may lead to problems in terms of anastomosis. The force use has to be gentle and it has to be, in a proper fashion. And nowadays we have got mechanized staplers also, whereby they distribute the force in an adequate fashion. And we should always check for any kind of staple line bleed. Sometimes we can lift it up even in laparoscopy and see, and be prepared to oversee or repair any kind of problem which is occurring at that point in time. We have always to check for anastomosis and its integrity. The types of staplers, again, linear NOR cutting, that is a TA staplers. We have all used it, especially in low anterior resection of the bowel. That is the only staple. Nowadays, it has come in tri-staple also. A few companies have come through, but usually it is a double staggered layer of staples. The third layer of staple is usually found in the vascular subtype. The closure of the hollow viscous end incision, that is enterotomies and ligation of large vessels, can also be done with this thing. The most commonly used are linear cutting staplers, that is GIA staplers. Both closes and transects the hollow viscera. First, delivering double, triple staggered loads of staple lines. And of course, after deploying the staple lines, they have a knife whereby you actually slide the knife and they cut it in between the 3 rows on either side. So they usually transect the tubular structures and may even create side-to-side anastomosis. Sometimes it may also be used to resect solid organs, and it is usually done in bariatric or metabolic surgeries. So these are the vascular staple lines, and in between there is a knife. There are circular staplers, which have usually a detachable anvil, that is the head. They place a circular double row. Nowadays, we also have a triple row, but double staggered row is the most commonly used. The diameter, that is the head diameter, and the staple line diameter, which is maybe in younger patients or kids, we may use 21, but usually the size is 33 millimeters in transverse diameter. Now, variably tight to close the staple height of 1 to 2.5 millimeter. It is used for inverted end-to-end or end-to-side anastomosis and may even be used in side-to-side, but usually it is not preferred. So this is the TA stapler. I have shown it from the Covidian or Medtronic. These are the circular staplers and laparoscopic staplers. The most important thing is the closed staple line and the open staple line. There are multiple colors available. The most important aspect is that the white is having the closest staple height line. So in thin or mesenteric or sometimes vascular area, you may use white. The blue, the open length is 3.5, but the close is 1.5. It is for the regular use. Gold for regular and thick, 1.8. Green for 2. So thicker tissues, you should use all these colors. Black, sometimes we use it for pylorus and adjacent to the pylorus, and also in the G junction, the black staple, which has got 2.3, and it is the thickest as of now in this counterpart. We have thicker staplers also, but this is the commonly used. These are the few pictorial representations. This is the tri-staple low from Ethicon, the upper one. It is cutting through the bowel, and we are doing stapled side-to-side anastomosis. The end here is sutured, which is shown in the right extreme corner. This is the circular stapler, which is firing through the anvil, and it is stapled end-to-side anastomosis. These are the staplers used for OAGB or one anastomosis gastric bypass, or also termed as MGB. Here we see that over a bouginage, we have opened the stapler, the second picture, after firing the stapler. It is a mechanized stapler, and then subsequently we are doing a gastrojejunostomy and closing the lumen after doing the anastomosis over with sutures. Sutures usually we use absorbable ones in this scenario, and we use 2 layers of sutures over here. This is again a pictorial representation of an endo-GIA stapler, 3-line stapler used laparoscopically, and whereby we may use it in LAR or APR. Finally, a word about suturing versus stapling. Both suturing and stapling techniques can be performed safely throughout the GI tract, and no significant differences are seen between clinical leak, morbidity, and even mortality. The studies have investigated the benefits of particular technique in specific situations. The staple versus hand sewn, there's a Cochrane review whereby it suggests that stapled side-to-side anastomosis is recommended following right hemicolectomy, particularly if performed for colonic adenocarcinoma. Side-to-side staple anastomosis, especially in Crohn's disease, it is not recommended to do a end-to-end anastomosis here. So majority of evidence considers or rather currently favors stapled side-to-side ileopholic anastomosis in Crohn's disease. But suturing may be an equivalent scenario. Especially in esophagus, sometimes the use of the stapler over the suturing line has also been suggested, especially in esophagogastric anastomosis. But here, one of the randomized study in hand-sewn anastomosis and stapled anastomosis, one suggested that more anastomotic leak in hand-sewn anastomosis and more anastomotic stricture also in hand-sewn anastomosis. So a strong indication was made for a stapled anastomosis. So stapled versus hand-sewn anastomosis in colorectal surgery. the evidences did not find or indicate any superiority over hand-sewn techniques in colorectal anastomosis. And it was regardless of the site of the anastomosis also, whether low down, upper, this thing, or even this thing. Sometimes people say that only the lower component was stapled and rest of the things should be hand-sewn, but the evidence suggests otherwise. Thank you for all the patient hearing. I hope I have stuck to my time. It was a brief overview of the techniques of anastomosis. Thank you.
Dr. Supe, I think we will move on with the presentations and come back to Anshuman later.
Sure, sir. Definitely.
Yeah. So, Peeyush, you are ready?
Yes, sir, I'm ready, sir.
I think there is a slide.
Can you just unshare your presentation so that we...
Yes, sir. I'm trying to do that, sir. Just a second, sir.
I'll do that.
So in the meantime, I'll introduce Peeyush. As I said earlier, Peeyush is again my former fellow from SGPGI, and now he's at the All India Institute of Medical Sciences in Jodhpur, and he's the one who has been managing the Friday afternoon Jaipur Surgical School. So there's a slight change. Vishal will come little later, so he will talk about the risk factors when he comes. Peeyush, please.
Am I audible and my slides are visible, sir?
Yes.
So thank you and good evening to everyone. First of all, I'd like to thank Professor Kapoor for this opportunity. So my topic is small bowel and anastomotic leak, including the right hemicolectomy. Although it seems to be easy as compared to other anastomotic leaks like esophageal or a colorectal anastomosis, but it is as important because I think every general surgeon and a GI surgeon will perform or is performing these anastomosis day in and day out. So just a brief introduction. So anastomotic leakage has been the bane of intestinal surgery for almost a century now. There has been a leak rate varying from around 1 to 2% to almost around 25%, depending upon the site of anastomosis. Around for right hemicolectomy, the leak rate is around 8 to 10%, and for small bowel anastomosis is around 1 to 5%. So anastomotic leaks increase the length of hospital stay. They have high readmission rates and higher mortality. So when wherever the reoperation is required, it creates a negative impact on the quality of life also, as well as a great financial loss to the patient as well as to the family. Although various surgical techniques and interventions have been developed to mitigate these leaks, but no effective solution is available. Define what is an anastomotic leak. It is a defect in the intestinal wall at or near the anastomotic site, including suture or staple lines of any neoreservoir leading to a communication between intra and extraluminal compartments. Any abscess that is close to the anastomosis is also considered an anastomotic leak. So it can be after any surgeries. I'll be particularly dealing with the small bowel anastomotic leak. This is a study, more a review article from multicentric middle-income countries, where they have depicted various leak rates after particular different anastomosis. And they have also highlighted that what an anastomotic leak can lead to. So there is an increased 18% mortality. It can lead to increased hospital stay and as well as additional cost due to increased hospital stay, patient trauma due to more formation of stomas, as well as decreased quality of life and patient discomfort. So why does it leak? So as already covered in the previous talk and will also be covered subsequently by Professor Vishal. So the mechanism of action for the leak is depending upon the site specific as well as local factors such as tissue and cellular morphology, what are the local digestive enzymes that are present there, what are the general and local tissue conditions. And most important is for what the surgery is being performed, especially in small bowel when the surgery is performed for tuberculosis, Crohn's disease, and other situations like mesenteric ischemia. So their proposed solutions can therefore differently vary according to the disease as well as the site. So it has always been debated that whether there can be a zero leak rate, but yet to encounter any study that can say that there is a zero leak rate. But yes, there can be certain measures and preventive measures which can decrease the leak rate. So I think these factors have already been covered in the previous talk by Dr. Anshuman, that the certain factors are modifiable and certain factors are non-modifiable. So among the modifiable factors are like preoperative, smoking, alcohol consumption, obesity, malnutrition, patient's albumin and protein level, stopping the NSAIDs, mechanical bowel preparations, and a preoperative systemic therapy. Intraoperative factors like vascularity of the bowels, type of suture material used, type of anastomosis, stapled or suture, type of approach, and whether the anastomosis diverting stoma is used, or how many blood transfusions are there intraoperatively. Non-modifiable factors are also there, such as like sex, comorbidity index, prior radiotherapy, or the tumor, the location of the tumor. So these factors are non-modifiable. There are certain strategies that can be used to prevent these leaks, but all these strategies have been described in literatures, but have not been propagated so rampantly because the effectiveness is not been studied, and its use is also not so frequent. Certain platform like sealants, which can be biologic and synthetics, have been used. Patches like biological patches from collagen, synthetic patches from polyglycolic acid, and interluminal device like C-seal, mechanical methods like suture, clipping. All these methods have been used, and like improved surgical technique. Recently, Dr. Anshuman discussed about the indocyanine green and other methods such as omental wrap. So every strategy has a pros and cons depending upon its property as well as the use. So these are certain advantages and disadvantages of these mitigation strategies. Like fibrin sealants, although they have a physiological sealing, but they do not form any adhesions and they have a rapid metabolism. And similarly, synthetic sealants have strong adhesions and create a strong inflammatory reactions. So they may increase post-operative adhesions and obstructions. Similarly, biomembranes in patches, they have immunogenicity and create a foreign body reactions. Certain Murphy button or endoluminal stents, sorry, endoluminal stents can create a rigidity and foreign body reactions and also lead to luminal stenosis. Similarly, omental wrap can also lead to adhesions and strictures, which can lead to post-operative obstruction. So all these strategies are there to reduce the anastomotic leak, but despite all these strategies, the anastomotic leak will happen and has to be managed very carefully. So how an anastomotic leak can present? It can present in any way, like peritonitis, pelvic, any abscess, pain, fever, tachycardia, or purulent or a feculent discharge from an abdominal drain placed during the surgery. So the diagnosis is quite easy if we are following the condition of the patient very carefully. And patient may present with fever, abdominal pain, distension, nausea, vomiting, and sometimes drainage from the surgical wound. Physical examination will lead to tachycardia, tachypnea, and signs of peritonitis. On investigation from blood investigation will obviously show the leukocytosis with neutrophilia, and cultures may be sent to identify the associated bloodstream organism, and electrolyte imbalances and markers of organ dysfunctions may be sent to assess the other organs functioning, such as serum creatinine and hypoperfusion of the organs. So first and foremost, if after stabilization of a patient, the gold standard image, the modality used for the diagnosis is the CT abdomen with oral and IV contrast. So like we see in this picture, we can see the extravasation of positive oral contrast from the anastomotic site and other indicators such as free intraperitoneal air, as well as enhancement of the peritoneal lining. These all indicates the anastomotic leak. Another picture which showed that the anastomotic leak from ileocolic anastomosis tracking down the abdominal wall through the wound. So all the just to highlight that the CT is the gold standard for diagnosing anastomotic leak. In some cases, a water-soluble contrast or a swallow study may be performed to evaluate the integrity of the anastomosis, especially for the esophageal anastomosis. Other modalities are used mainly for endoscopy, mainly for duodenal anastomosis may be used, and to assessing the upper GI anastomosis, but rarely used for small bowel anastomotic leaks. And also drain fluid analysis can be done if we suspicion anastomotic leak, which is not obviously frank. Regarding the late leaks, they have insidious presentation with low-grade fever, prolonged ileus, and sorry, non-specific symptoms. Small contained leaks may mimic post-operative abscess, and they are usually underreported and not counted as anastomotic leaks because of their varied presentation. So these are some of the real-time, real-world clinical photographs in which our patient presents as an anastomotic leak. This is one of the patient having feculent discharge from the main wound. This is another photograph in which the reoperation was done for anastomotic leak and suture line dehiscence was found, and then subsequently the abdomen was plastered and patient was managed with wound manager. So how to manage the anastomotic leak? So basic principles remains the same for any anastomotic leak, that to control the sepsis, to take care of the nutrition, especially the enteral nutrition, if required, nasojejunal tube or a feeding jejunostomy. And then finally, when the sepsis and nutrition is taken care of, to delineate the anatomy and to plan out what can be done next. So multiple factors are important. Most important is the what was the surgery done for, especially in the cases of mesenteric ischemia, tuberculosis, as well as Crohn's disease when the primary bowel is not healthy. So the management of leaks become difficult in these scenarios. Another important thing is the site. So the duodenal leaks are usually difficult to manage as compared to small bowel leaks. And when in small bowel, the proximal jejunal leaks are difficult as compared to the ileal leaks. So another factor is the duration. When is the presentation, early or late? And then depends what kind of management we are going to follow, a conservative or a surgical management. A word about duodenal leak. Duodenal leak is demanding and the situation is also rare. It may happen only after when we have performed surgeries for like excision of a duodenal gist, or we have repaired a duodenum during some other surgery, especially for a gallbladder cancer or cholecystectomy, and there is a dehiscence of the suture line of the duodenum. So the approach needs to be tailored in case-by-case fashion and depending upon several parameters. Most important are the interval between the operation and the diagnosis and the general condition of the patient. So if it is diagnosed early, within 4 to 7 days or less than that, then surgical revision or resuturing appears to be a feasible option if the risk of further damage is low. But with increasing time, the success rate of surgical closure decreases and it increases the risk of further injuries. So then the decision of surgical reintervention is made based on the surgeon experience and the expertise available. So the treatment options available for the duodenal leak can be primary closure or coverage from serosal flap or duodenal jejunostomy, or do a segmental duodenal resections, put a drainage tube for biliary diversions, and finally for a Whipple's procedure that is more technically demanding and should be carefully selected. IR may play an important role, especially in managing the collections, especially in duodenal leaks, when putting PCDs for undrained collections as well as PTBD for diverging bile. Nowadays, endoscopic facilities are also available at the centers of expertise and can be utilized to mitigate the effects of duodenal leak by duodenal stenting, CBD and pancreatic stenting, nasobiliary drainage for diversion, and NJ for nutrition. And other supportive measures such as antibiotics, somatostatin analogs, loperamide, parenteral nutrition, wound care and protections are important part in managing the duodenal leak. In case of a post-operative duodenal leak, spectrum of possible procedures is almost similar for the management of difficult duodenal stump. And if the primary suture of duodenum in the first operation was performed, then attempt to resuture should not be taken up, and because there will be a chance of leak subsequently. So other measures should be used as described in the previous table, like a duodenal jejunostomy can be performed, and additional biliary diversion procedures can also be performed. If all these procedures cannot be performed, then decision for resection should be taken very carefully, whether it has to be resected or multiple drainage has to be put down. Emergency Whipple's is a very demanding procedure with high morbidity and has to be considered carefully in only in the centers of expertise. Controlled surgical drainage in these situations is rather a more feasible options with placement of catheters into duodenum and other undrained places in Morrison pouch, and basically the goal is to make a stable fistula and do a resurgery when the patient is in a cold condition. So both surgical and interventional therapies have been accompanied with pharmacological therapies as described in the table. Antibiotics, fluid replacement, and parenteral nutrition also play an important role, especially managing the duodenal leak. Now coming to the management of small bowel leak. In contrast to duodenal leaks, isolated small bowel leaks are rare and also easier to manage. If detected in time, they can simply be treated by additional resection and re-anastomosis. However, most leaks occur as complications in more complex settings, such as peritonitis or multiple revisions, open abdomen and frozen abdomen, like cases of mesenteric ischemia and tuberculosis. So, like I already described, similar duodenal leaks, surgical revision should be adopted if the general and the local conditions allow and the tissue is healthy. But if there is increased duration of leak and associated peritonitis, then the surgical revision may not be feasible. So other interventional therapies should be used for managing these leaks. And often when the primary closure is not possible, then if there is only an isolated segment which can be resected and re-anastomosis is done, should be performed. If the re-anastomosis cannot be performed, the bowel tissues are not healthy, and we think that the anastomosis is going to leak, then making a stoma is a more feasible option and a safe option. Although making a stoma is safe, but it can lead to post-operative complications like stomal problems as well as small bowel syndromes associated with abdominal wall defects. So the decision should be made very carefully. And in complex situations with multiple enteric leaks, even a proximal jejunostomy can also be considered if no other option is available. In cases of recurrent leaks or frozen abdomen, all other options are impossible. Then obviously we have to do a bailout procedure, and placement of wide drainage catheters or applications of a vacuum assisted system over the entire abdominal wound can be used. And then subsequently the patient can be managed as a controlled enterocutaneous fistula. So just to summarize, that the principles of surgery when we are going in for a small bowel anastomotic leaks remains the same. That is, minimizing the extent of surgical intervention, shortening the procedure as much as possible, adequate drainage, and diversion wherever necessary. These are my concluding slides. These are certain recommendations from, although not from small bowel point of view, but have been by the Rectal Cancer Society, but holds true for the small bowel also. So they have divided into 3 grades just to categorize the patients and to manage these patients easily. And they have divided into 3 grades, A, B, and C. In grade A, the clinical condition is good, and with contents from the drain are usually serous, and patient general condition is good, and radiological evaluations also demonstrate a small or contained anastomotic leak. So generally, a conservative management can suffice, and there is no additional or increase in the hospital stay. In grade B, there is usually abdominal pain, fever, or there is some discharge from either the catheter or the wound site, and it may require additional intervention in the form of percutaneous drainage and antibiotics. Grade C is finally the patient is in florid sepsis and peritonitis and will require a redo surgery in the end, possibly a diversion. So this is an algorithm for managing a suspicious anastomotic leak. If the patient general condition is not good, then patient is having severe sepsis and peritonitis. Usually, patients are directly taken for laparotomy for either a stoma or a resection anastomosis. And if the patient condition is stable enough to get a CT scan, then always be evaluated with a CT scan and then accordingly graded as described in the previous table. Grade A can be managed conservatively. Grade B, if they are only small abscess, they can be dealt with antibiotics. Larger abscess may require percutaneous drainage, and larger abscess that are radiologically inaccessible may require surgical drainage. And in this algorithm, if always a patient deteriorates or patient develops signs of peritonitis, laparotomy is the only option, and to create a fecal diversion. Just to complete the list, endoscopic options are also available, but not commonly used for small bowel anastomotic leak. More commonly used for esophageal and colorectal anastomosis, like endoscopic clips and SAMs, and the endoluminal sponge therapy can also be used and will be dealt probably in subsequent talks. This is one of the image of through the scope clipping. This is my last slide before the summary. This is the study recently published in British Journal of Surgery in January and has been very popular and got almost more than 50,000 views, 15,000 views in last 3 months. So what they did was they took the surgeons from low volume centers from middle and low income countries and give them a strategic modules and step-by-step modules to educate them and inform them about the techniques of the anastomosis. And what they found was there was almost reduction in everything starting from clinical leak to death rate, reoperation, readmission, duration of hospital stay, unplanned admission to ICU, and making of unplanned stomas and defunctioning ileostomy with primary anastomosis. So they found that almost the leak rate reduced from 12.2% to almost 5% after intervention in high engagement centers. So the take-home message is that anastomotic leak is a severe complications and can be fatal, so should be taken very seriously as it can increase the morbidity and mortality. And if there is morbidity, it might delay the further chemotherapy, especially in cases of malignancies, and it may decrease the long-term survival. So early recognition and suspicion is the key to management. And there are various management options depending upon the general condition of the patient and when the leak is detected from operative to non-operative. And obviously, prevention is better than cure. So various techniques which can be modified and anastomotic leak can be prevented should be adopted. And as already discussed, there is no role of routine diverting stoma to prevent anastomotic leak. Thank you.
We can have 5 minutes comments from Dr. Supe and Dr. Sitaram before we move on to the next.
No. I think Sitaram, are you there? Okay, I'll start, sir.
Yes, yes, please.
First is Dr. Anshuman, actually. Anshuman, I think very nice presentation. You covered most of the points. I think I have only 1 or 2 comments to really make. One is, I think we have been using now ICG very often for colonic anastomosis, especially when we are doing it, and it is very useful. Especially if you're in doubt, I think ICG is very useful. And you have to really give it about few minutes before, and usually you see the bowel very well. You don't have to give it 2 hours like they give in the CPD. Immediately give it and you are able to see. And you are able to really then get an idea about your colonic level especially. The second point I wanted to make was in a ischemic bowel, if you are doing anastomosis, usually there are many, and we also don't put clamps actually. We don't put intestinal clamps. We try to do anastomosis without clamps. And many times we do single inverting rather than the classical, the double layer anastomosis. Because I think in an ischemic bowel, if you're doing anastomosis, we have to be a little more careful. And you don't have to put clamps and do that. These are the only 2 comments. And I wanted to ask you one question. Do you test the integrity of your anastomosis many times, especially in the lower colorectal or esophageal, and like putting water and then injecting the air or something like that, and how helpful it is in the literature?
Sir, a very nice question. Wherever we have an access, it is we prefer to do it, especially in upper part, whereby an esogastric tube or any kind of tube is there. Especially in laparoscopy, we always do that. Regarding the lower component, of course, we use an asepto syringe, as we call it, and then subsequently we just push in a bit of air. The important thing is that it should not be very vigorous. It should be gentle. And sometimes previous teaching was that you should not even try and do a very hard per rectal examination or try and do it. Why? Because you may actually jeopardize your anastomosis. But nowadays we do a gentle PR and we put in a bit of saline and subsequently try and look for any kind of on-table leak, as we call it. And literature, of course, we have got a few, it's individual rather assessment. We do not have a very large component. Even Professor Rajan had actually suggested something about it regarding the insufflation techniques in hepatobiliary surgery. And we have done that in bits and pieces. And if it is accessible. Yes, we'll always do that. Sometimes to push in a saline or air whereby we do not have an access may be questionable. It may be counterproductive sometimes whereby you are doing it at the evening after you're tired whole day of surgery. You may actually do a lot more harm. So nasogastric tube, having your anesthetic backup doing the things, especially in any kind of anastomosis in morbidly obese patient, in challenging patients, yes, of course, it is a must. And wherever we have access in this thing. And we've also tried to do that in a small bowel. Of course, we mobilize contents and put it in a kidney tray or a kidney bowl. And it is a no-brainer that you should do it. But having evidence, I'm not very sure.
Second question I wanted to ask you was that do you take over the sutures over the staple? There are many people who, after doing stapling, take another layer with hand with the submucous, subserosal kind of a stitch, layer they take over the staple line. So do you really?
So, okay. So personally, sir, in open surgeries, we used to do that while we had 2 layers of staple. Nowadays, we have got 3 layers of staple, and I think so it's an overkill sometimes that you try and do that. We have tried that in duodenal stump, especially in gastric carcinomas, and the distal gastrectomy, as we call it, the radical distal gastrectomy. And we have used sutures, predominantly proline, to actually bury the mucosa under the serosa. But I did not cover it because I thought that it was unnecessary for my talk. The staple form a figure of 8 kind of a scenario, whereby the mucosa is actually goes inside. And frankly, we have to understand that there are 3 layers doing roughly the same thing. How they do it is kind of questionable because we have to actually see it under the microscope sometimes maybe. But still, the lowermost layer is the most important. And what we have done essentially is that once we take out say we are doing a sleeve gastrectomy and we take out the specimen, we actually see the specimen also. And sometimes you stretch the specimen and you see the integrity. It is quite sturdy. So using perforce another layer of sutures may sometimes be unnecessary.
I fully agree with you. It's something like, if you look at the evidence in the literature, I think you will find single inverting is as good as doing double inverting, double layer. But I think most of us still prefer to do double layer inverting. That is what is probably it's mental kind of a thing which you get. We are not very happy many times with doing only single inverting, though literature is very clear that single layer inverting is as good as the double layer inverting. So I think these are some practices people follow. So we need to really look at those evidences and see how worth they are doing it or worth they are not doing it actually. Sitaram, you want to ask any questions?
Dr. Sitaram, any comment?
Yes, I have a few comments. I quite enjoyed both your talks, Anshuman and Peeyush.
Thank you.
Anshuman, I think one of your key slides was anastomotic leaks are caused by poor technique, vascularity, and tension. I think that is the key thrust, should be the key thrust of your presentation. In vascularity, personally, I feel that if you can see blood vessels close to the transaction margin pulsating, the arteries pulsating and the veins not being black, that is a very good indication that the vascularity is good and tension is quite obvious. You mentioned a large number of techniques of suturing. Whenever we have many options, that means we don't know what we are doing. We as surgeons collectively don't know what we are doing. So we should adopt for something that is simple and replicable in our hands. And I think nobody can say it better than the master Leonardo da Vinci. He said, simplicity is the best elegance and sophistication. So a simple technique of anastomosis using a monofilament suture which coapts bowel well is probably the best technique. You rightly said that one important consideration in stapled anastomosis is the bowel should not be edematous. And I think that has to be underlined. If you have edematous bowel, especially in the emergency situation, you should not use staples because those anastomosis that you create in edematous bowel are bound to fail. The other comment I want to make is the cost effectiveness of staples. We should not go away thinking that staples are an answer to many of our problems. I don't agree with that. We are still not a developed country. 2047 is still very far away, and we are a developing country, and surgery done in very small hospitals in the periphery. Surgeons should not think that stapled anastomosis is superior and I'm doing something inferior. I personally feel in those situations, a well done hands-on anastomosis is better than stapled anastomosis. And Peeyush, one of the things that I would like to say about reoperations for anastomotic leak, you have not mentioned abdominal compartment syndrome. At the end of the operation, very often, edematous bowel, you are unable to close the abdomen, and one should have a low threshold for closing only skin with a resultant large incisional hernia. But it's much better to have a live patient at the end of any operation. Thank you.
Peeyush, I just wanted to add one simple point. Actually, you said very rightly those international guidelines, but I think people, I mean, in addition to the clinical judgment, I think we should also do CRP and TNF levels. You know, these have been now recommended by many these guidelines that they help you in making an early diagnosis of an leak, especially in colorectal lesions. Though I don't know, we mainly use C-reactive protein. We don't use TNF alpha. And secondly, I think you said about WAC. You know, WAC I found very useful, especially in some of these below the peritoneum, lower rectal leaks. You know, they really help you well. And if you really do that, then WAC, especially that we have found it useful. Even in some cases of the esophageal leak, we have found endoscopic WAC very useful. So I think these are two areas of endoscopy which have been found useful in controlling these leaks, which are localized, I think. And that's where we should really use them.
Thank you, Peeyush and Anshuman. I think we'll move on. The next talk will be on esophageal anastomosis.
Thank you.
Which is one anastomosis which is very prone to leak. And we have Dr. Kalayarasan from JIPMER Puducherry to address this issue. Kalay, please come in and share your screen. Yeah. Yes. There is a black bar. There is a black bar.
It's gone actually.
Now it is okay.
Now there's one more above actually. Can you just see that?
I think it will
try to change the slide. I think it might go away.
I think it will go away. Yeah. Please start, Kalay.
Yes, sir. Thank you, sir. Thank you for the kind invitation. Actually, my video is not working, but I hope my audio is clear. So I'll be speaking on the esophageal anastomotic leak. We all know that's one of the primary contributor for the post-operative morbidity and mortality after esophagectomy. Also, we need to remember patients who have anastomotic leak, in addition to their post-operative problems, also have poor oncological outcomes because anastomotic leak often delays initiation of adjuvant therapy, and by the leak per se is known to also affect the long-term oncological outcomes. And we also know that most of these patients with a leak have a stricture, and which adversely affects their quality of life. So it's an important problem which we need to avoid, and also if it happens, we need to manage appropriately. The incidence shows, variable rate in the literature, which ranges from 5 to 30%. probably because some of the studies have included both the cervical and the thoracic leaks, while others predominantly have the thoracic anastomosis. In general, the thoracic anastomosis, the leak rate incidence is less compared to the cervical anastomotic leak rate. Also, the leak rates to some extent also depends upon the type of conduit which we are using. We all know following esophageal, while stomach is a commonly used conduit, but there are some scenarios where we use a colon and also even the jejunum. But in today's lecture, I primarily focus on gastric conduit being used as a for reconstruction. So we'll be discussing on post-esophagectomy, esophagogastric anastomosis, and the leaks related to that. So as I mentioned, the incidence of the leak rate is more with the cervical anastomosis compared to thoracic anastomosis, primarily because when the anastomosis is done in the neck, we will be using the fundus. And we all know that's the part of the stomach which is not supplied through the gastroepiploic arcade, but through the intramural arcade, which means that's a portion which will be having the less blood supply. And because in the neck, that's a part which is used for the anastomosis. Plus, because you require a long conduit when the anastomosis is done in the neck, and that can to some extent increase the tension. And the third factor which contributes is the compression at the level of the thoracic inlet, which primarily affect the venous outflow more than the arterial inflow. And it's well accepted that the cervical leaks are less severe compared to thoracic anastomosis, provided the leak is restricted to the neck. And we all know in at least 30 to 40% of the patients who have the cervical anastomosis, at the end of the procedure, the anastomosis descends up to the level of inlet, and the leaks can manifest with a thoracic collection, and there the severity differs. But when the leak is restricted to the neck, definitely the severity is less compared to the thoracic anastomotic leak rate. It's important to know the risk factors. So these are some of the risk factors which broadly they are classified as patient-related, the oncological, and the perioperative. The patient-related risk factors, the first is the nutritional, the hypoalbuminemia, and the comorbidities, especially the diabetes, hypertension. And there are also some evidence to show that atherosclerotic changes, especially in the celiac artery, influences the anastomotic healing, and obviously the steroids and use of immunosuppressants interfere with the healing. The oncological, the most important is because most of the patients now are operated after neoadjuvant chemoradiotherapy. The dose of radiation to the gastric fundus does play a role. And anti-angiogenic therapy, especially bevacizumab, if given in the preoperative setup, not commonly used, but used in selected cases, might again affect the healing. The perioperative factors, the most important is prolonged mechanical ventilation and the gastric disease, primarily the conduit dilatation. When the conduit gets dilated due to the obstruction at the level of pylorus, that can cause anastomotic leak, obviously the intraoperative hypotension, and the need for blood transfusion. So these are some of the risk factors. Some of them can be modified, whether some cannot be modified. The one other problem with respect in the literature is the varying definitions used to define the anastomotic leak rate and also the grading. To have a uniform definition in 2015, the esophagectomy complication consensus group came out with this the definition, which means a full thickness defect involving the esophagus, anastomosis, staple line, or conduit. So that's, I mean, even if there is a defect in the conduit, that's also considered as anastomotic leak, irrespective of the presentation or the method of identification, which means the leaks which are detected on imaging without even clinical features should also be considered as anastomotic leak. And this is the grading which is proposed. This is similar to what we commonly used in even the pancreatic anastomosis. The grade 1, which does not require any intervention. The grade 2 requires non-surgical intervention, and the grade 3 requires a surgical intervention. And someone who is interested can go through this manuscript, which also defines the other complications related to esophagectomy. The main aim of this consensus definition is so that we all speak in the same language, and it does help in coming out with guidelines subsequently. But the problem with this grading is, this is known after we manage the complications. But in the clinical practice, we want to know if this is the presentation, what we should be doing, which means we should have a classification that helps in deciding the right management option. So we have other gradings which can help us in the management. Now, this is primarily used for the cervical anastomosis. The type 1 leaks are those which are detected on imaging. So they don't have any clinical features. The type 2 are the ones which have the signs limited to the neck. And type 3 are the ones where the neck anastomotic leak results in thoracic collection. This is often happens when the anastomosis descends up to the level of thoracic inlet, then they manifest with the thoracic collection. And type 4 are the ones in which the leak is primarily due to the conduit necrosis, which can be either focal or diffuse. And this usually manifests with a significant systemic symptoms and signs. So the treatment strategy depends upon the type. The type 1, which is usually, this is the scenario in centers which follow a routine imaging before starting orals. And this is a scenario where you can pick up those type of subclinical leaks, and generally requires a period of observation with nil per oral and does not require any other intervention. The type 2, where the symptoms are primarily, the signs are primarily restricted to the neck. You open the neck wound and drain the collection. Most importantly, you inspect the conduit for any signs of ischemia. If there are no signs of ischemia, then these other patients can be just managed conservatively. Only thing, if you have the feeding jejunostomy, the management becomes more simple. You continue with the enteral feed. Otherwise, if feasible, to have a enteral feeding access. Some of these patients with minimal collection, you can even ask the patient to compress the neck and then keep taking the orals. And usually antibiotics are not required as long as they don't have any systemic signs. The type 3, because the leak results in thoracic collection, you would require an intercostal drainage. And in the neck, because the leak starts from the neck and then descends into the thorax. One of the technique which we have used in some of the patients is to have a kind of a vacuum dressing and then place a suction so that all the collection are drained out and they do not contaminate the thoracic cavity. The type 4, depending upon the extent of the ischemia, if it is a focal ischemia, probably you can use stenting. The only thing is you need at least 3 to 4 centimeter length from the cricopharyngeal sphincter. Otherwise, the stent can be really discomforting to the patient. The other option is if there is a significant ischemia, then the safest option is you dismantle, you excise the conduit and then do a esophageal diversion. And once the patient improves, you can use a alternate conduit. Now, moving on to the thoracic anastomotic leak, the treatment strategies again can be broadly classified as supportive care, which means you are not directly doing anything for the anastomotic leak, but you are something like ensuring the enteral feeding and antibiotics. The next is the drainage, which can be either by doing an intercostal, placing intercostal tube drainage or a surgical. Then closure of the defect, which could be using the endoscopic or the surgical and the diversion. So these are the treatment strategies. So how will you decide? So this is a score which has been proposed. This can be used both for thoracic and cervical, but however, if you see the score is derived from the database, which had predominantly the thoracic anastomotic leaks. And these are the predictors. Now, all these parameters used for this score, which is called the SEAL score or the severity of esophageal anastomotic leak, all these are based on the parameters which are available at the time of the patient is having leak, which means the day in which the leak is diagnosed, what was the level of care, whether the patient ward, ICU, what was the patient taking, whether the patient was just started on liquids or by the time the patient already started taking semi-solids, the leukocyte count, the resection type, which means the transthoracic, transhiatal, then quick SOFA score, which is the organ failure score, then hemodynamic status, respiratory status, renal status, intrathoracic fluid collections, what was the defect circumference and overall conduit condition, which means ischemic or vascularized. Now, all these are based on which means the parameters which are available to you at the time of diagnosis. And of this, the last three play a much more important role in determining the severity. Now, based on all these parameters, so the leak is classified into mild, which means the chance of 90-day mortality is less than 5%. A moderate means between 5 to 15, severe is 15 to 25, and critical is more than 25. Now, the typical example is a mild, the patient is diagnosed in the ward who is on liquid diet with a small defect, viable conduit, no organ failure. So these are the groups, which means mild. The moderate, a typical example is patient having an intrathoracic collection, a large defect with leukocytosis and either tachypnea or hypotension, but no organ failure. Now, severe is patient in ICU with organ failure along with these collections. And the critical means they have at least 25% chance of mortality, 90-day mortality. These are the patients with multiple organ failure. Now, the reason to have this type of severity prediction is those in the severe critical, so you'll have low threshold for surgical intervention. whereas in the mild and moderate, you start with less invasive intervention to manage. So, as I told, you have the conservative options, and in the intervention, you have both endoscopic and the surgical options. In the endoscopic, you have two options, which means the over the scope or through the scope clips. Over the scope clip in this means you first see the defect, then the scope is withdrawn, and over the scope, the clip is placed. So, because the clip is placed over the scope, it can be used for larger defects. Now, the through the scope clip means the clip is placed through the working channel of the endoscope, which means the clip diameter will be smaller and usually requires a multiple clips. And here, often you can manage with a single clip. The other endoscopic, so I'll just show a video of this is a patient after Ivor Lewis esophagectomy. Had a thoracic anastomotic leak, and you can see there. So this is the leak here. This is the anastomosis, and you can see the defect at the 3 o'clock roughly. So we have seen the defect, we have seen the size, and now the scope will be taken out. So you can see now the scope is being removed. And once the scope is removed, the clip is applied. And now the scope is introduced with the clip. And you can see here we have reached the defect. And using the suction force, the mucosa surrounding the defect is sucked into the scope, and then the clip is applied. Similar to the way we apply clips for esophageal varices. So somewhat similar mechanism. And so this, yeah, you can see now the mucosa is sucked inside, and then the clip is applied. So this is a technique of using the over the scope clip. So you can see the clip is applied now. The next option is stents. We all know about this stents, but what we use in anastomotic leak is the covered stent, either the plastic or the metallic option. And often to prevent the migration, you need to fix the stent. So that is one of the key point to remember when we use stents for anastomotic leak. I think this was mentioned by Supe sir about this endovac therapy. This is an emerging treatment option. So what is done in this? You can see this picture, which is labeled as A, B, C, D. So in the first step is you visualize the defect, you irrigate the cavity, and then you place something like the Riles tube. So the tube is placed through the nose, brought out through the mouth. Then to the tip of the tube, the sponge is sutured. And then with the guidance of the endoscope, this sponge is placed in the cavity. And then to the tube, you connect negative suction. That is, and so what it does is, with the negative suction, the collection, whatever the main reason why the anastomotic leak does not heal is because of the collection surrounding the anastomotic defect. And this collection prevents the leak. Now, once you apply a negative suction, all the collection is drained and slowly the cavity collapses. As the cavity collapses, the lung starts moving towards the defect. And at the end of probably 3 to 4 weeks, the defect is lined by the lung. And that's how the healing mechanism happens. So this is an emerging therapy called the endovac therapy. So you have a lot of endoscopic options. So how to choose the right one? There is a trend towards favoring clips and endovac therapy compared to the stent. Because you need to remember, the stent, when it is used in the setting of malignancy, you have the tumor which prevents the stent migration. But here, you have a normal mucosa, so the stent tends to migrate, although there are techniques to prevent it migration, but it does happen. And you don't want to add one more complication in a patient already suffering from a complication. So that's one of the problem in using stent. And second is, if there is some ischemia, the stent is proposed an option, but you need to remember that the expanding stents, it can worsen the ischemia and can even result in conduit airway fistula, that is with the trachea. So these are the problems. So there is a trend towards favoring a clip and the endovac therapy. Now you have many options with clips. You use through the scope clips for the small defect, maybe up to 1.5 centimeter. And over the scope clips can be used for defect up to 2.5 centimeter. And when there is associated collection, then endovac therapy is preferred, especially the defects of up to 2.5 to 3 centimeter. Now the surgical intervention, slowly with the endoscopic option, the need for surgical intervention is coming down. But however, you have to remember the patients in whom the non-operative interventions are not effective in reducing the systemic manifestations, then you need to intervene early. Previously, all thoracic anastomotic leaks, the general dictum is you need to intervene surgically, give a lavage. But now, slowly, up to 30 to 40 to 50% of the patients can be managed without any surgical intervention. But if you are intervening, if you are forced to intervene early because of early manifestation of leak, then these are the scenario where you can consider doing repair of the defect. But you need to remember that the patient should not be in sepsis, hemodynamic compromise should not be there, and even the surrounding tissue should be healthy. But most often we'll be intervening late, which means around after 5 to 7 days. In those scenarios, the aim of surgical intervention is to ensure a good lavage and then a controlled drainage. But if there is a significant defect or there is associated conduit ischemia, then you need to dismantle and then do a diversion. If the previous, the original surgery was minimal invasive, then minimal invasive re-intervention can be attempted if feasible, otherwise open intervention. Now, I'll just discuss some of the common questions which comes to any surgeon's mind when we talk about this esophageal anastomotic leak. Should you do a routine contrast study or endoscopy before starting orals? There is now reasonable consensus that for cervical anastomosis, you don't have to do them. But however, for thoracic anastomosis, prefer to have a contrast study before starting orals. What about the early oral feeding? Because now with the ERAS protocol, in most of the GI anastomosis, there is a trend towards starting early orals, that is from day one. It has been studied even in esophageal anastomosis. There are even a couple of randomized trials. What they have shown it is non-inferior. All these trials are non-inferiority trials. So the utility has been shown, but if you see the practice, it is still not widely practiced, because what is more important is early enteral feeding. So if you can achieve that by either feeding jejunostomy, or if you have a nasojejunal feed, then it is fine. So one of the concerns in starting early orals is because, especially if you're doing thoracic lymphadenectomy, there is a chance of recurrent laryngeal nerve palsy, even if not paralysis. There's some paresis can be there, and that can result in aspiration and pneumonia. So if you start orals without completely assessing the nerve status, so that's some of the reason why it is still not popular compared to other GI procedures. Whether neoadjuvant chemoradiation increase the risk, the most important thing is the dose of radiotherapy. Some studies have shown when the dose of radiotherapy to the area of anastomosis, that is fundus, exceeds 30 grays, it can increase the incidence of leak, while some studies have shown you up to 45 grays does not increase. We have studied in our center about this dose, and we could not find a significant correlation between the dose and the anastomotic leak rate. However, the sample size is less in this study. So this is the last part about the technical factors that can influence anastomotic leak. One is about the conduit diameter, because as I told, the tip of the conduit, the flow is determined only by the intramural through the muscular and the submucosal layer. So the ideal conduit is 3 to 5 centimeter. If it is less than 3 centimeter, then the venous outflow may not be sufficient. The conduit route, some studies have shown increased anastomotic leak rate with retrosternal, while some did not show any difference. A recent large Japanese database, which was published in 2022, which included 10,000 patients. In fact, in Japan, 2/3 of patients undergo retrosternal route, use a retrosternal route as a preferred route for the placement of conduit. And what they have shown is the posterior mediastinal may be also with less leak rate. The probable reason could be the narrow thoracic inlet has more influence when the conduit is placed in the retrosternal route compared to a posterior mediastinal route. What about the staple versus Anshuman anastomosis? The general consensus is there is no difference in leak rate. However, the stricture rate tends to be less following staple anastomosis. ICG fluorescence, yes, it can show if there is decreased perfusion and also when there is impaired outflow. The question is, you made the conduit and you brought it to the neck and then you give ICG. So what are the options left with you when you already made the conduit? The options are, you can probably resect the part of the conduit which is not well perfused if you have sufficient length, and then place your anastomosis to the well vascularized area. The other option is, if you have the short gastric vessel, then you can supercharge them in the neck. The low quality evidence, you don't have a very good evidence for this, but the low quality suggests there is a reduction in anastomotic leak rate. The other option is ischemic preconditioning, which means you ligate the left gastric vessel and the short gastric vessels probably before the patient is sent for neoadjuvant therapy. And this will improve the vascularity through the conduit, through the gastroepiploic arcade. Now, you have studies, even we have studied this. The variable research, some trials have shown benefit, some did not show any benefit. A recent systematic review does show there is a decrease in the anastomotic leak rate. Maybe you can use selectively in patients who are at risk. I have some videos, but I think due to the shortage of time, I'll skip them. This is showing about the type of how we do the anastomosis using staple, and this is about the ischemic preconditioning, but I think I'll skip them. So to conclude, although this is a very common problem, but the literature, you don't have a good literature to show what is the optimum management option for this type of leak. So probably this is one area of research. There's a lot of opportunity for research in this field. And so since you don't have any strong evidence, it is important to choose the right option based on the clinical presentation. That's the key factor to improve the outcomes. And as I mentioned previously, the step-up approach is preferred, especially when you have now good endoscopic options available. The understanding the risk factors and some of the technical modifications which have been shown to be beneficial could reduce the incidence of esophageal anastomotic leak. Thank you.
Thank you, Kalay. Normally we try to finish at 9, but since we lost few minutes today, we will go up to about 9:10. So Dr. Sitaram and Dr. Supe, any comments, and then we can move on.
Excellent presentation, Kalaya. I really enjoyed it. I think, I only wanted to ask you one or two small queries. Does robotic surgery coming in esophagus has reduced the anastomotic leak? That is one question. And second, I wanted to ask you that the way you handle esophagus while really bringing out foam into the neck is very important. I think many times people do mechanically, but if you really use what we use is a camera bag and we try to bring it through that. So avoid cause minimum damage to the esophagus. I think then the vascularity is maintained very well. So any other tips you want to give, technical tips for everyone to see whether they can reduce the leak or something like that?
Yes, sir. Yes, sir. I think I'll start with the second one, which you have asked about the handling the gastric conduit. Yes, using the camera cover as a to protect the conduit when while delivering it through the posterior mediastinum is a good option. Anything which prevent injury to the conduit while you are transferring it to the neck will help in minimizing the leak rate. Now, regarding the minimally invasive, I think, so what we do is, even when we are doing by minimally invasive approach, when we create the conduit, we actually give a small incision and do it as an open approach. We give a small incision, deliver the stomach out, then the process of forming conduit is done by open approach. That is primarily because we feel, I think that is a step which is critical in determining your anastomotic outcome. And we want to do it under full control. Plus also you can nicely stretch the conduit, get a good length. To somehow, although we do good number of minimalist procedures, that step we are comfortable doing with a small incision. Yes, sir.
Thank you so much. Sitaram, you can say.
Not qualified to comment. We'll move on.
Sure.
Come on, Sitaram.
I'll introduce the last speaker, Dr. Vishal Gupta, who is now the Chief of Surgical Gastroenterology at the All India Institute of Medical Sciences in Bhopal after serving.
Wow, Vishal, congratulations.
He was at the King George's Medical
College.
Yeah,
of course.
For a long time, but for the last, I think, 2 years, Vishal, you are
Good evening, sir. Good evening, sir. And, thank you. I joined in 2021, sir, July. So it's almost more than 2 years, sir.
Please start.
So I think many points have been covered. And first of all, I would like to thank the moderator chairperson to allow me to change my slot. And I would be the last speaker. And I think some of the points have already been covered, but I will just summarize them. And it is a kind of overview of the risk factors and what is the current evidence, what are the newer technologies, and what are the current concept with regards to these anastomotic leak risk factors. So So in this presentation, I will not be covering the biliary and the pancreatic anastomosis. It is mainly related to the luminal one. So we know that the ideal anastomosis in GI surgery means there should be no leak, no stricture, and it should function well. But this is not the reality because no anastomosis and the surgeon is 100% immune to the leak. And once leaks happens, it leads to many problems. Multiple interventions may be required. Hospital stay gets prolonged. Financial burden increases. It may lead to mortality. And once patient survives of this complication, there may be adverse long-term outcomes, especially the oncological outcomes. So this is just the incidence of anastomotic leak. Depending on the anastomotic site, it may be 5 to 21% in the esophagus. In the colorectal, it is up to 20%. And in the colorectal, as we go distally towards the pelvic floor, the incidence increases from 1 to 2% in the small bowel to up to 20% with the colorectal or coloanal anastomosis. So it is expected that esophagus and the rectum, they don't have any serosa. The expected leak rates, they are higher with the anastomosis involved in these organs. So broadly, we can classify the risk factor into different categories. So you can have preoperative, intraoperative, and postoperative risk factor. You can have surgeon-related and patient-related risk factors. And then you can have modifiable or non-modifiable risk factors. So we will go one by one. So we can have preoperative, non-modifiable or non-adjustable risk factors. So these are the risk factors which increase the risk of anastomotic leak. Before I go through this risk factor, if you go through the literature, most of the literature or studies, they are on the colorectal anastomosis or the esophageal anastomosis, very few are involving the small organ. So the male sex has been one of the important risk factor, higher ASA grade. Then we have comorbid condition like diabetes, pulmonary diseases, vascular diseases, renal diseases, all affect the vascularity. Then ex-smoker. So even if patient has stopped smoking, the risk persists even up to 10 years. Then history of radiotherapy in the form of radiation enteritis. So patient with CS cervix getting radiation in the previous few years, suffering from radiation enteritis might be at increased risk. Then you can have emergency surgery because bowel is dilated, edematous, there may be sepsis. Then distal anastomosis, I have already mentioned earlier, the rectum or the cervical anastomosis in case of esophageectomy. Large tumor size, advanced tumor stage, metastatic disease. So these are the all risk factors associated with the increased risk of anastomotic leak. Then we can have some potentially adjustable risk factors. So these are some modifiable risk factor preoperative, like smoking, obesity, not only the just high BMI, it is the visceral obesity which is also involved with the higher risk. Then alcohol consumption, malnutrition, and hypolipidemia. This is a traditional risk factor. Then, as already been mentioned in the last lecture by Dr. Kalay, the certain immunosuppressant drugs or antigenic medicines like bevacizumab, they are all involved with the higher risk of anastomotic leak. But these are the adjustable risk factor. Like for this bevacizumab, it is recommended to stop it at least 4 weeks before the surgery and then continue to restart after 4 weeks to minimize the effect of this drug on the anastomotic healing. Then we can have certain intraoperative risk factors like intraoperative contamination in case of perforation peritonitis, or when the surgery is prolonged more than 4 hours, patient requires intraoperative inotropic support. There is a higher blood loss. There is a need for multiple transfusion. Actually, the duration of surgery, blood loss, blood transfusion, needs for inotropes, it all indicates that surgery might have been difficult. Procedure is difficult. That's why it is prolonged. Blood loss is high. It needs blood transfusion. So these all factors are interrelated. And in terms of your rectal division, rectal resection like low anterior section, it has been found that requirement of more than one stapler cartridge, it increases the risk of anastomotic healing in the double stapling technique. But we also have certain factors which actually are associated with the decreased risk. So we can have preoperative antibiotics in the form of intraoperative intravenous antibiotic or the selective gut decombination that leads to decreased risk. Then we have stapled anastomosis, especially the ileocolic anastomosis, that has been shown to be associated with the decreased risk compared to hand sewn anastomosis. Then we can have thoracic anastomosis after the esophageectomy, having lower incidence of anastomotic leak compared to cervical anastomosis, and the proximal diversion, they are also associated with the decreased risk compared to no diversions. Then we can have certain risk factor in the post-op period. So patient was stable during the surgery, but patient developed shock in the post-op period because of various other reasons. Then this hypotension and hypoxia, that can also lead to increased risk of anastomotic leak. But certain other factors which we actually think of, like these are going to increase the risk of anastomotic leak. In terms of your current evidence, the literature is either there is inconclusive or there is no strong evidence to support these factors like age. It has been considered like age more than 60 or 75 is associated with the higher risk of leak, but that is not so. The neoadjuvant chemoradiotherapy, especially in CA rectum or esophagus, there is no conclusive evidence to support that this increases the risk of anastomotic leak. again with the mechanical bowel preparation, which is not going to increase the risk. Intraoperative hypothermia, theoretically, it seems like it is going to increase the risk. That is not so. Epidural analgesia, initially it was thought it is going to decrease the anastomotic leak by increasing the perfusion at the anastomotic site, but again, there is no concrete evidence. NaCIT, there is some evidence that diclofenac can increase the anastomotic leak if used in the post-op period. Then there have been studies with regards to restricted versus liberal IV fluid replacement in the post-op period. Again, no difference in the leak rate. Low versus high ligation of IMA and LAR. Again, no difference. Laparoscopic versus open rectal resection or esophagectomy. Again, no difference. Initially, it was thought that omentoplasty can decrease the leak rate by giving additional vascularity to the anastomotic site, but again, by going by the evidence, no difference. And again, abdominal drain is not going to affect the anastomotic leak. Although it was initially thought that with placing the drain, there may be early detection of the anastomotic, but again, there is no effective change. Now, coming to the other aspect of risk factors. Conventionally, we over a period of many decades actually, and based on wisdom of practicing surgeon, initially certain risk factors were defined for the anastomotic leak. And these conventional wisdom-based risk factors are technique, surgical technique, tension of the anastomosis, tissue perfusion or ischemia, and divisional status. But one by one, we will go through each of these risk factors. What does the current literature mention about this risk factor? So coming to the anastomotic technique, does it really matter? So the technique considered, we always think that technique of the anastomosis plays a critical role in maintaining the anastomotic integrity. But exactly what is the optimal technique? It is still not clear. It has remained elusive and uncertain. That's why we have so many techniques, from suture to technique, suture material, suture format, single versus two layer, then interrupted versus continuous. Then we have stapler mechanical devices and so many other things. But all of them has failed to demonstrate any consistent benefit in terms of lower leak rates, except the staple anastomosis involving the ileopubic anastomosis after the right colon resection, which shows that staple anastomosis have some advantage over the hand-stone anastomosis. So the anastomotic technique, we have to think it again that it is important, but it is not the sole thing to prevent the anastomotic leak. Then again, tension-free anastomosis, does it actually relieve surgeon's tension? Conventionally, tension-free anastomosis is one of the basic tenets of the safe anastomosis. But exact role of this tension-free anastomosis is not clear. It was claimed that tension plays an important role in the anastomotic leak, but it remains unsubstantiated based on the literature, especially at the individual patient level when the leak actually occurs. There is no definitive animal studies or convincing clinical studies which implicates that tension is an important or very important risk factor. In fact, there is one study in 2008 in which the anastomotic leak rate was not found to be different when the splenic fracture was mobilized or without mobilized during the high colorectal anastomosis. Conventionally, it is recommended that you should mobilize the splenic fracture to allow a tension-free colorectal anastomosis, but this study suggests that this is not actually the case. There was no difference in the anastomotic leak rate in this study. So again, going through all these points, we have to rethink that tension-free anastomosis is definitely important, but again, it is not the only thing. Coming to the tissue perfusion on ischemia, I think this has been discussed detailedly in last few lectures. We know that ischemia is a commonly implicated risk factor because hypoxia impairs the collagen synthesis. This leads to impaired collagen reinforcement of the anastomosis during the proliferative phase. And because of this, there is a dehiscence and finally there is a clinical leak. And traditionally, we assess the perfusion intraoperatively by certain subjective methods like pulsation, bleeding, or the color of the bowel at the anastomotic site. But these are subjective and not very reliable. So with the neo technology, we have come to the certain things like ICG fluoroscopy for a better objective assessment, but does it supported by the literature? Again, going to the literature, we have mixed result. It might be beneficial, but all studies have not consistently shown any benefit. Like this flag trial in 2020, it shows there is some benefit for the low colorectal anastomosis, but for the high anastomosis, it was not found to be beneficial. Still, we have a 1.3% leak rate versus 4.6%. Another trial, Pillar 3 trial in 2021, no benefit in the low anterior section. And this latest trial in 2023, it shows that it may be beneficial in the left rectal section because of the lower leak rate. But you have to understand that even with the ICG use, we still have some leak rate. Like in this FLAG 2020 trial, it was beneficial for the low colorectal anastomosis, but at the same time, the leak rate was 14%. It was not nil. It decreased from 25 to 14%, but still 14% is a significant number despite using the ICG. And the same with the essential 22-23 trial, the leak rate was 7.6% despite using the ICG. So with the colorectal anastomosis, results are mixed. It might be beneficial. Maybe we have some more strong data in future to suggest its routine use, but as of now, it cannot be recommended for the routine use. So the coming to the esophagectomy, again, we have the mixed results. Like this study, this was a systematic review and meta-analysis published in 2022. It shows there is a no benefit. Large number of patients, more than 3,000, and leak rate with the ICG still was 9% compared to 9% in other group without using the ICG. So they have concluded that it does not seem to reduce the anastomotic leak rate in patient undergoing minimally invasive esophagectomy with intrathoracic anastomosis. This analysis was focused mainly on the intrathoracic anastomosis. Another meta-analysis published 2 years back that shows that there is some benefit for the cervical anastomosis, but not for the thoracic anastomosis. Again, we need to understand that even with the ICG, leak occurred in nearly 5% of the patient. So it is not something that if you use it, there will be no leak. So now we have to think of certain factors beyond the conventional factor. And now the role of intestinal microbiome is re-emerging in general and also for the anastomotic leak. And we know that intestinal microbiomes, there are trillions of organisms within the GI tract. And this host microbiome interaction plays an important critical role in maintaining the intestinal homeostasis. And this concept of effect of our bacteria in the gut on the anastomosis is actually not new. In 1956, there was some animal experiment in dogs when the anastomotic leak rate decreased to near zero when the antibiotic was injected in the anastomotic site. And the leak rate was 80% without antibiotic. And mind you, in both the groups, the anastomotic site was devascularized. So even with the devascularization with antibiotic injected in the anastomotic site, leak rate was zero. And there is a recent reemergence in this area, and there are few studies in humans when they actually analyze the microbiome on the resected mucus in the donut after the rectal resection, and they found that in patients with leak, there is a high abundance of certain bacterial strain like Bacteroideaceae and Lactobacillus. So it is assumed that certain bacteria with collagenase producing strain, they can colonize the anastomotic site and they can play some role in increasing the risk of leak. But still, we don't have sufficient evidence to suggest their role so that we can have some mitigating certain thing to address this intestinal microbiome to reduce the anastomotic leak rate. So just to summarize, the anastomotic leak is still they are an enigma for the surgeon. Usually they are multifactorial, and it is very difficult to predict with high accuracy which anastomosis will fail. And once that happens, it is very difficult to pinpoint what actually went wrong. And we need to understand that problem of leak is actually related more to the biology than to the physics. And as a surgeon, we remain focused more on the physics. But once anastomotic leak happens, our focus immediately shift to the biology of the patient. We think that there is something happens with the patient. There are certain patient-related factors that played role in anastomotic heal rather than our technique. So with this thing, I will just conclude my presentation. Thank you.
Thank you, Vishal. Concluding remarks from Dr. Supe and Dr. Sitaram, please.
I think, can you just unshare your presentation, Vishal?
Sure, sir.
Thank you, Vishal, for bringing out many points, a few points which were not really brought. Something like clarity about the ICG and its limitations, which is going on in the literature. I think you brought it very well. As well as the another point you also brought about the newer thinking about microbiota and other things, how they are going to affect. So actually, these are the two areas which are still we are thinking about it. And in spite of all the technologically advantages which we have with the new kind of imaging energy sources and staplers, the leak rates have gone down, but they have not gone completely zero. I think this is what is the final thing we should all remember, is that it is the, as you rightly said in the last slide, it's not only physics, but it's the functioning biology which is very important. So I think everything matters. You know, the way you do pre-operatively rehabilitation of these patients, the way you take decisions on the table, the way you use all these techniques, and post-operatively how you are alert to find out a leak. I think all that really matters. I think I'm really happy to have all the 4 presentations really brought out very important points. And I'm sure all listeners will be very happy with this. I think over to Sitaram.
Vishal, I thoroughly enjoyed your presentation because you challenged many of my pet beliefs in this topic. I would love to have a conversation with you on this topic. It was really very good listening to you. Thank you very much.
Thank you, sir.
Any other faculty colleagues present would like to make any comment before we close? Okay, so if no, then I would like to thank all the 4 speakers and Dr. Sitaram and Dr. Shastri, you are there. Would you like to say something?
I think, Shastri, are you there? No, I think it's.
Thank you, Dr. Sitaram, Dr. Supe, for accepting my request. Thank you very much. And we'll meet again tomorrow at 7 p.m. for the remaining 3 presentations.
Thank you, sir. Thank you.
Thank you, sir. Good night, sir.
Night.
Thank you, sir.
Thank you, Avinash and Himanshi and the Dwarika Hospital team. Thank you very much.
Okay, well, stop live stream.